Let us begin by understanding inflammation. It is not simply a random occurrence, but rather a dynamic pathological process, a fundamental defense mechanism of nature. The body, in its biological wisdom, mounts an active resistance against harmful agents. The ultimate goal is simple yet profound: to destroy the injurious stimulus, or at the very least, to minimize the damage it causes. Remember, inflammation is not chaos. It is the body's organized strategy for survival. Now, how do we define inflammation? It is the local response of living mammalian tissue to injury, orchestrated by the vigilant forces of leukocytes and plasma proteins rushing to the site of harm. But what provokes such a response? Many agents: physical trauma, corrosive chemicals, invading microbes, and even immunological misfires of the body itself. One crucial point to etch in your mind: inflammation is not the same as infection. Infection may cause inflammation, yes, but inflammation can exist even without infection. Centuries ago, the Roman scholar Celsus gave us the 4 cardinal signs of inflammation: Rubor, Tumor, Calor, and Dolor. Redness, swelling, heat, and pain. These timeless words still guide us today, reminding us that even ancient physicians recognized the visible and tangible marks of the body's battle within. Inflammation takes 2 distinct paths: acute and chronic. Let us first consider acute inflammation. It is swift, short-lived, and represents the body's early reaction to injury. The battlefield is marked by 3 key features: fluid and plasma pouring into the affected site, platelets activating within vessels, and the arrival of the first responders, the polymorphonuclear neutrophils. Acute inflammation is the spark, the immediate cry of defense. Chronic inflammation, however, is a different story. It arises when the assault is relentless, or when the process is chronic from the very beginning. Here, the warriors are different. Lymphocytes, plasma cells, and macrophages dominate the scene. Unlike the fleeting rush of acute inflammation, chronic inflammation settles in, a slow-burning fire. To understand it, we must divide the changes into 2 grand categories: vascular events and cellular events. Let us first explore the vascular events. These are the changes in the microvasculature: the arteries, the venules, the capillaries. They are the highways of the body's defense, and they undergo dramatic alterations during inflammation. These include shifts in blood flow and changes in the very permeability of the vessels themselves. The hemodynamic story unfolds in a sequence. At first, there is a brief spasm, a transient vasoconstriction, but soon after comes persistent and progressive vasodilation. This is why inflamed tissue glows red and burns with heat. The local hydrostatic pressure rises, the blood slows, circulation stagnates, and with this stasis, leukocytes begin to line the vessel walls, preparing to exit into the battlefield beyond. This is inflammation in motion. Now, as the vessels change, permeability is altered. Fluid escapes into the interstitial spaces, accumulating around the inflamed tissue. In the earliest moments, this fluid is a transudate, mere plasma filtrate from vasodilation. But soon, as the vessel walls grow more permeable, it becomes an exudate, rich in proteins, a fluid of true inflammation. Finally, we must distinguish between transudate and exudate. Transudate is but a simple filtrate of blood, a bland, non-inflammatory fluid. It holds little protein, normal glucose, low specific gravity, and only a few scattered cells. Exudate, however, is different. It is born of inflammation, rich in proteins, heavy with cells, acidic in nature, and laden with lactate dehydrogenase. It is the hallmark of an active, ongoing inflammatory response. This distinction is vital for understanding the pathology that lies beneath.